After completing this chapter, you will be able to 1. Identify the purposes of the physical examination. 2. Explain the 4 techniques used in physical examination: inspection, palpation, percussion, and auscultation. 3. Identify expected findings during health assessment. 4. Verbalize the steps used in performing selected examination procedures. A. Assessing appearance and mental status. B. Assessing the skin. C. Assessing the hair. D. Assessing the nails. E. Assessing the skull and face. F. Assessing the eye structures and visual acuity. G. Assessing the ears and hearing. H. Assessing the nose and sinuses. I. Assessing the mouth and oropharynx. J. Assessing the neck. K. Assessing the thorax and lungs. Key terms: adventitious breath sounds, 555 alopecia, 528 angle of Lewis, 553 antihelix, 539 aphasia, 580 astigmatism, 533 auricle, 539 auscultation, 519 Blanche test, 530 brute, 562 caries, 546 cataracts, 533 cerumen, 539 clubbing, 530 cochlea, 540 conductive hearing loss, 540 conjunctivitis, 533 cyanosis, 523 dacrocystitis, 533 diastole, 561 dullness, 519 duration, 519 edema, 523 erythema, 523 eustachian tube, 540 exophthalmos, 532 external auditory meatus, 539 extinction, 582 fasciculation, 577 flatness, 519 fremitus, 557 gingivitis, 546 glaucoma, 533 glossitis, 546 goniometer, 579 helix, 539 hernia, 593 hordeolum, sty, 533 hyperopia, 533 hyperresonance, 519 incus, 540 inspection, 517 intensity, 519 intention tremor, 514 Unit 7 Assessing health. The location of the examination, and the agency's priorities and procedures. The order of head-to-toe assessment is given in box 30-1. Regardless of the procedure used, the client's energy and time need to be considered. The health assessment is therefore conducted in a systematic and efficient manner that results in the fewest position changes for the client. Frequently, nurses assess a specific body area instead of the entire body. These specific assessments are made in relation to client complaints, the nurse's own observation of problems, the client's present ING problem, nursing interventions provided, and medical therapies. Examples of these situations and assessments are provided in Table 30-1. These are some of the purposes of the physical examination. To obtain baseline data about the client's functional abilities. To supplement, confirm, or refute data obtained in the nursing history. To obtain data that will help establish nursing diagnoses and plans of care. To evaluate the physiological outcomes of healthcare, and thus the progress of a client's health problem. To make clinical judgments about a client's health status. To identify areas for health promotion and disease prevention. Introduction. Assessing a client's health status is a major component of nursing care, and has two aspects: 1. The nursing health history discussed in Chapter 11, and 2. The physical examination discussed in this chapter. A physical examination can be any of three types. 1. A complete assessment, example, when a client is admitted to a healthcare agency. 2. Examination of a body system, example, the cardiovascular system. Or 3. Examination of a body area, example, the lungs, when difficulty with breathing is observed. Note: some nurses consider assessment to be the broad term used in applying the nursing process to health data, and examination to be the physical process used to gather the data. In this text, the terms assessment and examination are sometimes used interchangeably, both referring to a critical investigation and evaluation of client status. Physical health assessment. A complete health assessment may be conducted starting at the head and proceeding in a systematic manner downward, head-to-toe assessment. However, the procedure can vary according to the age of the individual, the severity of the illness, the preferences of the nurse. Box 30-1 head-to-toe framework. General survey: vital signs: head, hair, scalp, face, eyes and vision, ears and hearing, nose, mouth and oropharynx, neck, muscles, lymph nodes, trachea, thyroid gland, carotid arteries, neck, veins, upper extremities, skin and nails, muscle strength and tone, joint range of motion, brachial and radial pulses, sensation. Chest and back, skin, thorax shape and size, lungs, heart, spinal column, breasts and axilla, abdomen, skin, abdominal sounds, femoral pulses, external genitals, anus, lower extremities, skin and toenails, gait and balance, joint range of motion, popliteal, posterior tibial and dorsalis pedis pulses. Table 30-1 nursing assessments addressing selected client situations. Situation: physical assessment. Client complains of abdominal pain. Inspect, auscultate, percuss, and palpate the abdomen. Assess vital signs. Client is admitted with a head injury. Assess level of consciousness using Glasgow Coma Scale. See Table 30-10 later in this chapter. Assess pupils for reaction to light and accommodation. Assess vital signs. The nurse prepares to administer a cardiotonic drug to a client. Assess apical pulse and compare with baseline data. The client has just had a cast applied to the lower leg. Assess peripheral perfusion of toes, capillary Blanche test, pedal pulse if able, and vital signs. The client's fluid intake is minimal. Assess tissue turgor, fluid intake and output, and vital signs. M30_Berm 4362_10_SE_CH 30.IND 514 April 12, 11 a.m. Chapter 30 Health Assessment 515. Number 153613 CUST, Pearson, Berman PG. Number 515. Title, Kozier and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. And neck, heart and lungs, and range of motion can be done early in the process, with the ears, mouth, abdomen, and genitals being left for the end of the exam. Preparing the environment. It is important to prepare the environment before starting the assessment. The time for the physical assessment should be convenient to both the client and the nurse. The environment needs to be well lighted, and the equipment should be organized for efficient use. A client who is physically relaxed will usually experience little discomfort. The room should be warm enough to be comfortable for the client. Providing privacy is important. Most people are embarrassed if their bodies are exposed, or if others can overhear or view them during the assessment. Culture, age, and gender of both the client and the nurses use national guidelines and evidence-based practice to focus health assessment on specific conditions. The nurse's judgment is key when the evidence is inconclusive or conflicting. For example, when screening for cancer, nurses should keep in mind the American Cancer Society's guidelines for early detection, box 30-2. However, whereas those guidelines call for mammography every year beginning at age 40, the U.S. Preventive Services Task Force, 2009, recommends breast mammography only every 2 years for women ages 50 to 74, and none thereafter. Preparing the client. Most people need an explanation of the physical examination. Often clients are anxious about what the nurse will find. They can be reassured during the examination by explanations at each step. The nurse should explain when and where the examination will take place, why it is important, and what will happen. Instruct the client that all information gathered and documented during the assessment is kept confidential in accordance with the Health Insurance Portability and Accountability Act, HIPAA. This means that only those healthcare providers who have a legitimate need to know the client's information will have access to it. Health examinations are usually painless, however, it is important to determine in advance any positions that are contraindicated for a particular client. The nurse assists the client as needed to undress and put on a gown. Clients should empty their bladders before the examination. Doing so helps them feel more relaxed and facilitates palpation of the abdomen and pubic area. If a urinary cis is required, the urine should be collected in a container for that purpose. When assessing adults, it is important to recognize that people of the same age differ markedly. Box 30-3 provides special considerations for assessing adults, especially older adults. The sequence of the assessment differs with children and adults. With children, always proceed from the least invasive or uncomfort-able aspect of the exam to the more invasive. Examination of the head. Box 30-2 Cancer Screening Guidelines for Asymptomatic People. Colorectal cancer, males and females, fecal occult blood test, or fecal immunochemical test annually beginning at age 50, or stool DNA test, may be done beginning at age 50. Flexible sigmoidoscopy every 5 years beginning at age 50, or colonoscopy every 10 years beginning at age 50, or double contrast barium enema every 5 years beginning at age 50. Computerized tomography colonography every 5 years beginning at age 50. Breast cancer, females, beginning in their early 20s, women should be told about the benefits and limitations of breast self-examination, BSE, and the importance of reporting breast symptoms to a health professional. Those who choose to perform BSE should receive instruction and have their technique reviewed regularly. Women may choose to perform BSE regularly, occasionally, or not at all. Clinical breast examination every 3 years from ages 20 to 40, and then annually beginning at age 40. Mammogram annually at age 40 and over. Cervical and uterine cancer, females, for women ages 21 to 29, screening every 3 years with Pap tests. For women ages 30 to 65, screening every 5 years with both HPV test and the Pap test, or every 3 years with the Pap test alone. Women ages 65 and older, who have had greater than or equal to 3 consecutive negative Pap tests, or greater than or equal to 2 consecutive negative HPV and Pap tests in the last 10 years, the most recent test in the last 5 years, and women who have had a total hysterectomy should stop cervical cancer screening. Prostate cancer, males, for men who have at least a 10-year life expectancy, discussion with the primary care provider about the benefits, risks, and uncertainties associated with prostate cancer screening. Health counseling and cancer checkup, males and females, over age 20 examination for cancers of the thyroid, testicles, ovaries, lymph nodes, oral region, and skin during the regular health examination from cancer screening in the United States, 2014. A review of current American Cancer Society guidelines and current issues in cancer screening by R. A. Smith, D. Manassaram Baptiste, D. Brooks, V. Cockenides, M. Dorschenk, D. Saslow. O. W. Brawley, 2014, CA, A Cancer Journal for Clinicians, 64, pages 31 to 51. Box 30-3 Health Assessment of the Adult. Be aware of normal physiological changes that occur with AGING. See the lifespan considerations later in this chapter. Be aware of stiffness of muscles and joints from aging or history of orthopedic surgery. The client may need modifica tie-in of the usual positioning necessary for examination and assessment. Expose only areas of the body to be examined in order to avoid chilling. Permit ample time for the client to answer your questions and assume the required positions. Be aware of cultural differences. The client may want a family member present during disrobing. Arrange for an interpreter if the client's language differs from that of the nurse. Ask clients how they wish to be addressed, such as Mrs. or Mississippi. Adapt assessment techniques to any sensory impairment. For example, make sure eyeglasses or hearing aids are nearby. If clients are older or frail, it is wise to conduct the assessment in several segments in order to not overtire them. M30_Berm4360_10_SE_CH30.IND515 April 12, 14:11 a.m. Number 153613 CUST, Pearsono, Berman PG Number 516 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 516 Unit 7 Assessing Health. Nurse influence how comfortable the client will be and what special arrangements might be needed. For example, if the client and nurse are of different genders, the nurse should ask if it is acceptable to perform the physical examination. Family and friends should not be present unless the client asks for someone. Positioning. Several positions are frequently required during the physical assessment. It is important to consider the client's ability to assume a position. The client's physical condition, energy level, and age should also be taken into consideration. Some positions are embarrassing and uncomfortable, and therefore should not be maintained for long. The assessment is organized so that several body areas can be assessed in one position, thus minimizing the number of position changes needed. Table 30-2. Position description areas assessed. Cautions. Dorsal recumbent back lying position with knees flexed and hips externally rotated, small pillow under the head, soles of feet on the surface. Female genitals, rectum, and female reproductive tract may be contraindicated for clients who have cardiopulmonary problems. Supine, horizontal recumbent, back lying position with legs extended, with or without pillow under the head. Head, neck, axilla, anterior thorax, lungs, breasts, heart, vital signs, abdomen, extremities, peripheral pulses. Tolerated poorly by clients with cardiovascular and respiratory problems. Sitting a seated position, back unsupported and legs hanging freely. Head, neck, posterior and anterior thorax, lungs, breasts, axilla, heart, vital signs, upper and lower extremities, reflexes. Older adults and weak clients may require support. Lithotomy back lying position with feet supported in stirrups. The hips should be in line with the edge of the table. Female genitals, rectum, and female reproductive tract may be uncomfortable and tiring for older adults and often embarrassing. Sims side lying position with lowermost arm behind the body, uppermost leg flexed at hip and knee, upper arm flexed at shoulder and elbow. Rectum, vagina difficult for older adults and people with limited joint movement. Prone lies on abdomen with head turned to the side, with or without a small pillow. Posterior thorax, hip joint movement often not tolerated by older adults and people with cardiovascular and respiratory problems. Table 30-2 Client positions and body areas assessed. Draping. Drapes should be arranged so that the area to be assessed is exposed and other body areas are covered. Exposure of the body is frequently embarrassing to clients. Drapes provide not only a degree of privacy, but also warmth. Drapes are made of paper, cloth, or bed linen. Instrumentation. All equipment required for the health assessment should be clean, in good working order, and readily accessible. Equipment is frequently set up on trays, ready for use. Various instruments are shown in Table 30-3. Methods of examining. For primary techniques are used in the physical examination, inspection, palpation, percussion, and auscultation. These techniques. M30_42-10_SE_CH30.IND516 April 12, 14:11 a.m. Chapter 30 Health Assessment 517. Number 153613 CUST, Pearsono, Berman PG Number 517 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Figure 30-1 The position of the hand for light palpation. Supplies purpose flashlight or pen light to assist viewing of the pharynx, or to determine the reactions of the pupils of the eye. Ophthalmoscope, a lighted instrument to visualize the interior of the eye. Otoscope, a lighted instrument to visualize the eardrum and external auditory canal. A nasal speculum may be attached to the otoscope to inspect the nasal cavities. Percussion, reflex, hammer, an instrument with a rubber head to test reflexes. Tuning fork, a two-pronged metal instrument used to test hearing acuity and vibratory sense. Cotton applicators to obtain specimens. Gloves to protect the nurse. Tongue blades, depressors, to depress the tongue during assessment of the mouth and pharynx. Table 30-3 equipment and supplies used for a health examination are discussed throughout this chapter as they apply to each body system. Inspection. Inspection is the visual examination, which is assessing by using the sense of sight. It should be deliberate, purposeful, and systematic. The nurse inspects with the naked eye and with a lighted instrument, such as an otoscope, used to view the ear. In addition to visual observations, olfactory, smell, and auditory, hearing, cues are noted. Nurses frequently use visual inspection to assess moisture, color, and texture of body surfaces, as well as shape, position, size, color, and symmetry of the body. Lighting must be sufficient for the nurse to see clearly. Either natural or artificial light can be used. When using the auditory senses, it is important to have a quiet environment for accurate hearing. Inspection can be combined with the other assessment techniques. Palpation. Palpation is the examination of the body using the sense of touch. The pads of the fingers are used because their concentration of nerve endings makes them highly sensitive to tactile discrimination. Palpation is used to determine a. Texture, example, of the hair, b. Temperature, example, of a skin area, c. Vibration, example, of a joint, d. Position, size, consistency, and mobility of organs or masses, e. Distension, example, of the urinary bladder, f. Pulsation, and g. Tenderness or pain. There are two types of palpation, light and deep. Light, superficial palpation should always precede deep palpation, because heavy pressure on the fingertips can dull the sense of touch. For light palpation, the nurse extends the dominant hand's fingers parallel to the skin surface, and presses gently while moving the hand in a circle, figure 30:1. With light palpation, the skin is slightly depressed. If it is necessary to determine the details of a mass, the nurse presses lightly several times, rather than holding the pressure. See box 30-4 for the characteristics of masses. M30_Berm 4362_10_SE_CH 30.IND 517 April 12, 11 a.m. Number 153613 CUST, Pearson, Berman PG Number 518 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 518 Unit 7 Assessing Health. Percussion. Percussion is the act of striking the body surface to elicit sounds that can be heard or vibrations that can be felt. There are two types of percussion, direct and indirect. In direct percussion, the nurse strikes the area to be percussed directly with the pads of 2, 3, or 4 fingers, or with the pad of the middle finger. The strikes are rapid, and the movement is from the wrist. This technique is not generally used to percuss the thorax, but is useful in percussing an adult's sinuses, figure 30-4. Indirect percussion is the striking of an object, example, a finger, held against the body area to be examined. In this technique, the middle finger of the non-dominant hand, referred to as the pleximeter, is placed firmly on the client's skin. Only the distal phalanx and joint of this finger should be in contact with the skin. Using the tip of the flexed middle finger of the other hand, called the plexor, the nurse strikes the pleximeter, usually at the distal interphalangeal joint or a point between the distal and proximal joints, figure 30-5. The striking motion comes from the wrist, the forearm remains Deep palpation is usually not done during a routine examination and requires significant practitioner skill. It is performed with extreme caution because pressure can damage internal organs. It is usually not indicated in clients who have acute abdominal pain or pain that is not yet diagnosed. Deep palpation is done with 2 hands, bimanually, or 1 hand. In deep bimanual palpation, the nurse extends the dominant hand as for light palpation, then places the finger pads of the non-dominant hand on the dorsal surface of the distal interphalangeal joint of the middle 3 fingers of the dominant hand, figure 30-2. The top hand applies pressure while the lower hand remains relaxed to perceive the tactile sensations. For deep palpation using 1 hand, the finger pads of the dominant hand press over the area to be palpated. Often the other hand is used to support from below, figure 30-3. To test skin temperature, it is best to use the dorsum, back of the hand and fingers, where the examiner's skin is thinnest. To test for 6 bradyon, the nurse should use the palmar surface of the hand. General guidelines for palpation include the following. The nurse's hands should be clean and warm, and the fingernails short. Areas of tenderness should be palpated last. Deep palpation should be done after superficial palpation. The effectiveness of palpation depends largely on the client's relaxation. Nurses can assist a client to relax by a. Gowning and/or draping the client appropriately, b. Positioning the client comfortably, and c. Ensuring that their own hands are warm before beginning. During palpation, the nurse should be sensitive to the client's verbal and facial expressions indicating discomfort. Figure 30-4 direct percussion. Using 1 hand to strike the surface of the body. Figure 30-2 the position of the hands for deep bimanual palpation. Figure 30-3 deep palpation using the lower hand to support the body, while the upper hand palpates the organ. Location, site on the body, dorsal/ventral surface size, length and width in centimeters, shape, oval, round, elongated, irregular consistency, soft, firm, hard surface, smooth, nodular mobility, fixed, mobile pulsatility, present or absent tenderness, degree of tenderness to palpation. Box 30-4 characteristics of masses. M30_Berm 4362_10_SE_CH 30.IND 518 April 12, 11 a.m. Chapter 30 Health Assessment 519. Number 153613 CUST, Pearson O. Berman PG Number 519 Title, Kozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. The stethoscope tubing should be 30-35 centimeters, 12-14 inches. Long, with an internal diameter of about 0.3 centimeters 1/8 inches. It should have both a flat disc diaphragm and a bell-shaped amplifier. See Figure 4 in Skill 29-3 on page 493. The diaphragm best transmits high-pitched sounds, example, bronchial sounds, and the bell best transmits low-pitched sounds such as some heart sounds. The earpieces of the stethoscope should fit comfortably into the nurse's ears, facing forward. The amplifier of the stethoscope is placed firmly but lightly against the client's skin. If the client has excessive hair, it may be necessary to dampen the hairs with a moist cloth, so that they will lie flat against the skin, and not interfere with clear sound transmission. Auscultated sounds are described according to their pitch, intensity, duration, and quality. The pitch is the frequency of the 6 bradyons, the number of vibrations per second. Low-pitched sounds, such as some heart sounds, have fewer vibrations per second than high-pitched sounds, such as bronchial sounds. The intensity, amplitude, refers to the loudness or softness of a sound. Some body sounds are loud, for example, bronchial sounds heard from the trachea. Others are soft, for example, normal breath sounds heard in the lungs. The duration of a sound is its length, long or short. The quality of sound is a subjective description of a sound, for example, whistling, gurgling, or snapping. General survey. Health assessment begins with a general survey that involves observation of the client's general appearance, level of comfort, and mental status, and measurement of vital signs, height, and weight. Many components of the general survey are assessed while taking the client's health history, such as the client's body build, posture, hygiene, and mental status, see Chapter 11. Appearance and mental status. The general appearance and behavior of an individual must be assessed in relationship to culture, educational level, socio-economic status, and current circumstances. For example, an individual who has recently experienced a personal loss may appropriately appear depressed, sad expression, slumped posture. The client's age, sex, and race are also useful factors in interpret findings that suggest increased risk for known conditions. Skill 30-1 describes how to assess general appearance and mental status. Skill 30-17 later in this chapter describes a mental status examination in detail. Stationary. The angle between the plexor and the pleximeter should be 90 degrees, and the blows must be firm, rapid, and short to obtain a clear sound. Percussion is used to determine the size and shape of internal organs by establishing their borders. It indicates whether tissue is fluid-filled, air-filled, or solid. Percussion elicits 5 types of sound: flatness, dullness, resonance, hyperresonance, and tympany. Flatness is an extremely dull sound produced by very dense tissue, such as muscle or bone. Dullness is a thud-like sound produced by dense tissue such as the liver, spleen, or heart. Resonance is a hollow sound such as that produced by lungs filled with air. Hyperresonance is not produced in the normal body. It is described as booming, and can be heard over an emphysematous lung. Tympany is a musical or drum-like sound produced from an air-filled stomach. On a continuum, flatness reflects the most dense tissue, the least amount of air, and tympany the least dense tissue, the greatest amount of air. A percussion sound is described according to its intensity, pitch, duration, and quality, Table 30-4. Auscultation. Auscultation is the process of listening to sounds produced within the body. Auscultation may be direct or indirect. Direct auscultation is performed using the unaided ear, for example, to listen to a respiratory wheeze or the grating of a moving joint. Indirect auscultation is performed using a stethoscope, which transmits sounds to the nurse's ears. A stethoscope is used primarily to listen to sounds from within the body, such as bowel sounds or valve sounds of the heart and blood pressure. Figure 30-5. Indirect percussion. Using the finger of one hand to tap the finger of the other hand. Sound intensity, pitch, duration, quality. Example of location: flatness, soft, high, short, extremely dull, muscle, bone dullness, medium, medium, moderate, thud-like, liver, heart. Resonance: loud, low, long, hollow, normal, lung. Hyperresonance: very loud, very low, very long, booming, emphysematous, lung. Tympany: loud, high, distinguished mainly by musical timbre, moderate, musical, stomach filled with gas, air. Table 30-4. Percussion sounds and tones. M30_Berm 4362_10_SE_CH 30.IND 519 April 12, 11 a.m. Number 153613 CUST, Pearson O. Berman PG Number 520 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 520 Unit 7 Assessing Health. Assessing Appearance and Mental Status. Skill 30-1. Planning delegation. Due to the substantial knowledge and skill required, assessment of general appearance and mental status is not delegated to unlicensed assistive personnel, UAP. However, many aspects are observed during usual care and may be recorded by individuals other than the nurse. Abnormal findings must be validated and interpreted by the nurse. Interprofessional practice. Assessing appearance and mental status is within the scope of practice of many healthcare providers other than nurses before, during, and after their treatments. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment none. 2. Perform hand hygiene and observe other appropriate infection prevention procedures. 3. Provide for client privacy. Implementation Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. Assessment Normal findings Deviations from normal. 4. Observe for signs of distress in posture or facial expression. No distress noted bending over because of abdominal pain, wincing, frowning, or labored breathing. 5. Observe body build, height, and weight in relation to the client's age, lifestyle, and health. Proportionate, varies with lifestyle excessively thin or obese. 6. Observe client's posture and gait, standing, sitting, and walking. Relaxed, erect posture, coordinated movement tense, slouched, bent posture, uncoordinated movement, tremors, unbalanced gait. 7. Observe client's overall hygiene and grooming. Clean, neat, dirty, unkempt. 8. Note body and breath odor. No body odor or minor body odor relative to work or exercise. No breath odor. Foul body odor, ammonia odor, acetone breath odor, foul breath. 9. Note obvious signs of health or illness, example, in skin color or breathing. Well-developed, well-nourished, intact skin, easy breathing, pallor, paleness, weakness, lesions, cough. 10. Assess the client's attitude, frame of mind. Cooperative, able to follow instructions. Negative, hostile, withdrawn, anxious. 11. Note the client's affect/mood. Assess the appropriateness of the client's responses. Appropriate to situation, inappropriate to situation, sudden mood change, paranoia. 12. Listen for quantity of speech, amount and pace, quality, loudness, clarity, inflection. Understandable, moderate pace, clear tone, and inflection. Rapid or slow pace, overly loud or soft. 13. Listen for relevance and organization of thoughts. Logical sequence, makes sense, has sense of reality. Illogical sequence, flight of ideas, confusion, generalizations, vague. 14. Document findings in the client record using printed or electronic forms, and checklists supplemented by narrative notes when appropriate. Evaluation. Perform a detailed follow-up examination of specific systems, based on findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. Report significant deviations from expected or normal findings to the primary care provider. M30_BERM 4362_10_SE_CH 30.IND 520 April 12, 14, 11 a.m. Chapter 30 Health Assessment 521. Number 153613 CUST, Pearson, Berman PG Number 521 Title, Kozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing Appearance and Mental Status, Continued. Skill 30-1. Nursing Assessment Form. Nursing Assessment Form from Cerner Electronic Health Record. Copyright by Cerner Corporation. Used by permission of Cerner Corporation. M30_BERM 4362_10_SE_CH 30.IND 521 April 12, 14, 11 a.m. Number 153613 CUST, Pearson, Berman PG Number 522 Title, Kozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 522 Unit 7 Assessing Health. Is assessed. In some instances, the nurse may also use the olfactory sense to detect unusual skin odors. These are usually most evident in the skin folds or in the axillae. Pungent body odor is frequently related to poor hygiene, hyperhidrosis, excessive perspiration, or bromidrosis, foul-smelling perspiration. Integument. The integument includes the skin, hair, and nails. The examination begins with a generalized inspection using a good source of lighting, preferably indirect natural daylight. Skin. Assessment of the skin involves inspection and palpation. The entire skin surface may be assessed at one time, or as each aspect of the body. Vital signs. Vital signs are measured, A, to establish baseline data against which to compare future measurements, and B, to detect actual and potential health problems. See Chapter 29 for measurements of temperature, pulse, respirations, blood pressure, and oxygen saturation. See Chapter 46 for pain assessment. Height and weight. In adults, the ratio of weight to height provides a general measure of health. By asking clients about their height and weight before actually measuring them, the nurse obtains some idea of the person's self-image. Excessive discrepancies between the client's responses and the measurements may provide clues to actual or potential problems in self-concept. Take note of any unintentional weight gain or loss last ing, or progressing over several weeks. The nurse measures height with a measuring stick attached to weight scales or to a wall. The client should remove the shoes and stand erect, with heels together, and the heels, buttocks, and back of the head against the measuring stick. Eyes should be looking straight ahead. The nurse raises the L-shaped sliding arm until it rests on top of the client's head, or places a small flat object, such as a ruler or book, on the client's head. The edge of the flat object should abut the measuring guide. Weight is usually measured when a client is admitted to a health care agency and then often regularly thereafter, for example, each morning before breakfast and after emptying the bladder. Scales measure in pounds, lb, or kilograms, kg, and the nurse may need to convert between the two systems. 1 kilogram is equal to 2.2 pounds. When accuracy is essential, the nurse should use the same scale each time, because every scale weighs slightly differently. Take the measurements at the same time each day, and make sure the client has on a similar kind of clothing and no footwear. The weight is read from a digital display panel or a balancing arm. Clients who cannot stand are weighed on chair, figure 30:6, or bed scales. The bed scales, figure 30:7, have canvas straps or a stretcher-like apparatus to support the client. A machine lifts the client above the bed, and the weight is reflected either on a digital display panel or on a balance arm like that of a standing scale. Newer hospital beds have built-in scales. Figure 30:6 chair scale. Courtesy Detecto scale. Figure 30:7 bed scale. Clinical alert. Review the agency charting form before beginning your assessment to ensure that you know which data you will need to collect, have all the equipment you require, and know how to perform the assessment in a systematic manner. M30_BERM 4362_10_SE_CH 30.IND 522 April 12, 14, 11 a.m. Chapter 30 Health Assessment 523. Number 153613 CUST, Pearson, Berman PG Number 523 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Home Care Considerations General Survey. Assess the client in private whenever possible. If a family member is needed to assist with recall of events or translation, obtain the client's permission to have the family member present. Use your own equipment when possible in measuring vital signs. Bring a tape measure for measuring height. Recognize that the client's home scale for measuring weight may not be accurate. Patient-centered care. Pallor is the result of inadequate circulating blood, or hemoglobin, and subsequent reduction in tissue oxygenation. In clients with dark skin, it is usually characterized by the absence of underlying red tones in the skin, and may be most readily seen in the buccal mucosa. In brown-skinned clients, Pallor may appear as a yellowish-brown tinge. In black-skinned clients, the skin may appear ashen gray. Pallor in all people is usually most evident in areas with the least pigmentation, such as the conjunctiva, oral mucous membranes, nail beds, palms of the hand, and soles of the feet. Cyanosis, a bluish tinge, is most evident in the nail beds, lips, and buccal mucosa. In dark-skinned clients, close inspection of the palpebral conjunctiva, the lining of the eyelids, and palms and soles may also show evidence of cyanosis. Jaundice, a yellowish tinge, may first be evident in the sclera of the eyes, and then in the mucus. Membranes and the skin. Nurses should take care not to confuse jaundice with the normal yellow pigmentation in the sclera of a dark-skinned client. If jaundice is suspected, the posterior part of the hard palate should also be inspected for a yellowish color tone. Erythema is skin redness associated with a variety of rashes and other conditions. Localized areas of hyperpigmentation, increased pigmentation, and hypopigmentation, decreased pigmentation, may occur as a result of changes in the distribution of melanin, the dark pigment, or in the function of the melanocytes in the epidermis. An example of hyperpigmentation in a defined area is a birthmark. An example of hypopigmentation is vitiligo. Vitiligo, seen as patches of hypopigmented skin, is caused by the destruction of melanocytes in the area. Albinism is the complete or partial lack of melanin in the skin, hair, and eyes. Other localized color changes may indicate a problem, such as edema, or a localized infection. Dark-skinned clients normally have areas of lighter pigmentation, such as the palms, lips, and nail beds. Edema is the presence of excess interstitial fluid. An area of edema appears swollen, shiny, and taut and tends to blanch the skin color or, if accompanied by inflammation, may redden the skin. Generalized edema is most often an indication of impaired venous circulation, and in some cases reflects cardiac dysfunction or venous abnormalities. A skin lesion is an alteration in a client's normal skin appearance. Primary skin lesions are those that appear initially in response to some change in the external or internal environment of the skin, figure 30-8. Secondary skin lesions are those that do not appear initially but result from modifications such as chronicity, trauma, or infection of the primary lesion. For example, a vesicle or blister, primary lesion, may rupture and cause an erosion, secondary lesion. Table 30-5 illustrates secondary lesions. Nurses are responsible for describing skin lesions accurately in terms of location, example, face, distribution, i.e., body regions involved, and configuration, the arrangement or position of several lesions, as well as color, shape, size, firmness, texture, and characteristics of individual lesions. Skill 30-2 describes how to assess the skin. Lifespan Considerations General Survey. Infants' observation of children's behavior can provide important data for the general survey, including physical development, neuromuscular function, and social and interactional skills. It may be helpful to have parents hold older infants and very young children for part of the assessment. Measure height of children under age 2 in the supine position, with knees fully extended. Weigh without clothing. Include measurement of head circumference until age 2. Standardized growth charts include head circumference up to age 3. Children anxiety in preschool-age children can be decreased by letting them handle and become familiar with examination equipment. School-age children may be very modest and shy about expose ing parts of the body. Adolescents should be examined without parents present. Weigh children without shoes and with as little clothing as possible. Older adults allow extra time for clients to answer questions. Adapt questioning techniques as appropriate for clients with hearing or visual limitations. Older adults can lose several inches in height. Be sure to document height and ask if they are aware of becoming shorter in height. When asking about weight loss, be specific about amount and time frame. For example, have you lost more than 5 pounds in the last 2 months? How much did you weigh 1 year ago? M30_Berm4360_10_SE_CH30.IND523 April 12, 14:11 a.m. Number 153613 Pearsono, Berman PG number 524 title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K short/normal. Design Services of S4 Carlisle Publishing Services. Figure 30 to 8 Primary Skin Lesions. Figures Dr. P. Marazzi/Science Source, Scott Kamazine/Alami, Mediskin/Alami, PSIP/SA/Alami, Welcome Image Library/Custom Medical Stock Photo, Hercules Robinson/Alami, P. Marazzi/Photo Researchers/Science Source. Macule, patch flat, unelevated change in color. Macules are 1 mm to 1 cm, 0.04 to 0.4 in size and circumscribed. Examples, freckles, measles, petechiae, flat moles. Patches are larger than 1 cm 0.4 inches, and may have an irregular shape. Examples, port wine birthmark, vitiligo, white patches, rubella. Papule circumscribed, solid elevation of skin. Papules are less than 1 cm 0.4 inches. Examples, warts, acne, pimples, elevated moles. Plaques are larger than 1 cm 0.4 inches. Examples, psoriasis, rubeola. Psoriasis papular drug eruption. A caféolemacule. Nodule, tumor elevated, solid, hard mass that extends deeper into the dermis than a papule. Nodules have a circumscribed border, and are 0.5 to 2 centimeters, 0.2 to 0.8 inches. Examples, squamous cell carcinoma, fibroma. Tumors are larger than 2 centimeters, 0.8 inches, and may have an irregular border. Examples, malignant melanoma, hemangioma. Nodules from Recklinghausen's disease. Pustule vesicle or bulla filled with pus. Examples, acne vulgaris, impetigo. White pustules along with darker healing areas. Vesicle, bulla a circumscribed, round or oval, thin translucent mass filled with serous fluid or blood. Vesicles are less than 0.5 centimeters 0.2 inches. Examples, herpes simplex, early chicken pox, small burn blister. Bulli are larger than 0.5 centimeters 0.2 inches. Examples, large blister, second-degree burn, herpes simplex. Bullous pemphigoid. Cyst a 1 centimeter 0.4 inches or larger, elevated, encapsulated, fluid-filled or semi-solid mass arising from the subcutaneous tissue or dermis. Examples, sebaceous and epidermoid cysts, chalazion of the eyelid. Digital mucus cyst. Wheel a reddened, localized collection of edema fluid, irregular in shape. Size varies. Examples, hives, mosquito bites. Allergic wheals, urticaria. 524. M30_Berm4360_10_SE_CH30.IND524 April 12, 14:11:02 a.m. Chapter 30 Health Assessment 525. Number 153613 CUST, Pearsono, Berman PG number 525 title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K short/normal Design Services of S4 Carlisle Publishing Services. Atrophy, a translucent, dry, paper-like, sometimes wrinkled skin surface resulting from thinning or wasting of the skin due to loss of collagen and elastin. Examples, striae, aged skin. Ulcer, deep, irregularly shaped area of skin loss extending into the dermis or subcutaneous tissue. May bleed. May leave scar. Examples, pressure ulcers, stasis ulcers, chancres. Erosion, wearing away of the superficial epidermis causing a moist, shallow depression. Because erosions do not extend into the dermis, they heal without scarring. Examples: scratch marks, ruptured vesicles. Fissure, linear crack with sharp edges, extending into the dermis. Examples: cracks at the corners of the mouth or in the hands, athlete's foot. Lichenification, rough, thickened, hardened area of epidermis resulting from chronic irritation such as scratching or rubbing. Examples: chronic dermatitis. Scar, flat, irregular area of connective tissue left after a lesion or wound has healed. New scars may be red or purple, older scars may be silvery or white. Examples: healed surgical wound or injury, healed acne. Scales, shedding flakes of greasy, keratinized skin tissue. Color may be white, gray, or silver. Texture may vary from fine to thick. Examples: dry skin, dandruff, psoriasis, and eczema. Keloid, elevated, irregular, darkened area of excess scar tissue caused by excessive collagen formation during healing. Extends beyond the site of the original injury. Higher incidence in people of African descent. Examples: keloid from ear piercing or surgery, crust, dry blood, serum, or pus left on the skin surface when vesicles or pustules burst. Can be red, brown, orange, or yellow. Large crusts that adhere to the skin surface are called scabs. Examples: eczema, impetigo, herpes, or scabs following abrasion. Excoriation, linear erosion. Examples: scratches, some chemical burns. Table 30-5 Secondary skin lesions. Planning, review characteristics of primary and secondary skin lesions, if necessary, see Figure 30-8 and Table 30-5. Ensure that adequate lighting is available. Delegation. Due to the substantial knowledge and skill required, assessment of the skin is not delegated to UAP. However, the skin is observed during usual care, and UAPs should record their findings. Abnormal findings must be validated and interpreted by the nurse. Interprofessional practice. Assessing the skin may be within the scope of practice of many healthcare providers other than nurses. For example, physical therapists and occupational therapists may notice edema or skin lesions during treatment. Although these other providers may verbally communicate their findings and plan to healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment: millimeter ruler, clean gloves, magnifying glass. Assessing the skin. Skill 30-2. Continued on page 526. M30_Berm 4362_10_SE_CH30.IND 525 April 12, 11:03 a.m. Number 153613 CUST, Pearson O. Berman PG Number 526 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 526 Unit 7 Assessing Health. 2 mm, 4 mm, 6 mm, 8 mm. 1 plus 2 plus 3 plus 4 plus. Implementation Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene and observe other appropriate infection prevention procedures. 3. Provide for client privacy. 4. Inquire if the client has any history of the following: pain or itching, presence and spread of lesions, bruises, abrasions, pigmented spots, previous experience with skin problems, associated clinical signs, family history, presence of problems in other family members, related systemic conditions, use of medications. Lotions, home remedies, excessively dry or moist feel to the skin, tendency to bruise easily, association of the problem to season of year, stress, occupation, medications, recent travel, housing, and so on, recent contact with allergens, example, metal paint. Clinical alert. If you have not already gathered relevant information about the client's history, as it relates to the specific area being assessed, do so before beginning the physical examination. This allows you to focus the examination, customized to the individual client history and current status. Assessment normal findings deviations from normal. 5. Inspect skin color, best assessed under natural light. Light and on areas not exposed to the sun. Varies from light to deep brown, from ruddy pink to light pink, from yellow overtones to olive. Pallor, cyanosis, jaundice, erythema. 6. Inspect uniformity of skin color. Generally uniform except in areas exposed to the sun, areas of lighter pigmentation, palms, lips, nail beds, in dark-skinned people. Areas of either hyperpigmentation or hypopigmentation. 7. Assess edema, if present, i.e., location, color, temperature, shape, and the degree to which the skin remains indented or pitted when pressed by a finger. Measuring the circumference of the extremity with a millimeter tape may be useful for future comparison. No edema. See the scale for describing edema. 8. Inspect, palpate, and describe skin lesions. Apply gloves if lesions are open or draining. Palpate lesions to determine shape and texture. Describe lesions according to location, distribution, color, configuration, size, shape, type, or structure. Box 30-5 on page 527. Use the millimeter ruler to measure lesions. If gloves were applied, remove and discard gloves. Perform hand hygiene. Freckles, some birthmarks that have not changed since childhood, and some long-standing vascular birthmarks, such as strawberry or port wine hemangiomas, some flat and raised nevi, no abrasions or other lesions. Various interruptions in skin integrity, irregular, multicolored, or raised nevi, some pigmented birthmarks, such as melanocystic nevi, and some vascular birthmarks, such as cavernous hemangiomas. Even these deviations from normal may not be dangerous or require treatment. Assessment by an advanced level practitioner is required. 9. Observe and palpate skin moisture. Moisture in skin folds and the axillae varies with environmental temperature and humidity, body temperature, and activity. Excessive moisture, example, in hyperthermia, excessive dryness, example, in dehydration. Scale for grading edema. Assessing the skin, continued. Skill 30-2. M30_Berm 4362_10_SE_CH 30.IND 526 April 12, 11:03 a.m. Chapter 30 Health Assessment 527. Number 153613 CUST, Pearson, Berman PG Number 527 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing the skin, continued. Skill 30-2. Assessment normal findings deviations from normal. 10. Palpate skin temperature. Compare the 2 feet and the 2 hands, using the backs of your fingers. Uniform, within normal range generalized hyperthermia, example, in fever, generalized hypothermia, example, in shock, localized hyperthermia, example, in infection, localized hypothermia, example, in arteriosclerosis. 11. Note skin turgor, fullness or elasticity, by lifting and pinching the skin on an extremity, or on the sternum. When pinched, skin springs back to previous state, is elastic, may be slower in older adults. Skin stays pinched or tented or moves back slowly, example, in dehydration. Count in seconds how long the skin remains tented. There is no widely accepted time span distinguishing normal from abnormal skin turgor, De Vries-Fayens and De Jager, 2011. 12. Remove and discard gloves. Perform hand hygiene. 13. Document findings in the client record using printed or electronic forms, or checklists supplemented by narrative notes when appropriate. Draw location of skin lesions on body surface diagrams. Clinical alert. If agency policy permits and the client agrees, take a digital or instant photograph of significant skin lesions for the client record. Include a measuring guide, ruler or tape, in the picture to demonstrate lesion size. Right, left, left, right. Diagram for charting skin lesions. Evaluation. Compare findings to previous skin assessment data, if available, to determine if lesions or abnormalities are changing. Report significant deviations from expected or normal findings to the primary care provider. Box 30-5. Type or structure. Skin lesions are classified as primary, those that appear initially in response to some change in the external or internal environment of the skin, and secondary, those that do not appear initially but result from modifications such as chronicity, trauma, or infection of the primary lesion. For example, a vesicle, primary lesion, may rupture and cause an erosion, secondary lesion. Size, shape, and texture. Note size in millimeters and whether the lesion is circumscribed or irregular, round or oval shaped, flat, elevated, or depressed, solid, soft, or hard, rough or thickened, fluid-filled or has flakes. Color. There may be no discoloration, one discrete color, example, red, brown, or black, or several colors, as with ecchymosis. A bruise, in which an initial dark red or blue color fades to a yellow color. When color changes are limited to the edges of a lesion, they are described as circumscribed. When spread over a large area, they are described as diffuse. Distribution. Distribution is described according to the location of the lesions on the body, and symmetry or asymmetry of findings in comparable body areas. Configuration. Configuration refers to the arrangement of lesions in relation to each other. Configurations of lesions may be annular, arranged in a circle, clustered together, grouped, linear, arranged in a line, arc or bow-shaped, or merged, indiscrete, may follow the course of cutaneous nerves, or may be meshed in the form of a network. Describing skin lesions. M30_Berm 4362_10_SE_CH30.IND527 April 12, 11:03 a.m. Number 153613 CUST, Pearson, Berman PG Number 528 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. 528 Unit 7 Assessing Health. Lifespan Considerations Assessing the Skin. Infants' physiological jaundice may appear in newborns 2 to 3 days after birth, and usually lasts about 1 week. Pathologic jaundice, or that which indicates a disease, appears within 24 hours of birth, and may last more than 8 days. Newborns may have milia, whiteheads, small white nodules over the nose and face, and vernix caseosa, white cheesy, greasy material on the skin. Premature infants may have lanugo, a fine downy hair covering their shoulders and back. In dark-skinned infants, areas of hyperpigmentation may be found on the back, especially in the sacral area. Diaper dermatitis may be seen in infants. If a rash is present, inquire in detail about immunization history. Assess skin turgor by pinching the skin on the abdomen. Children normally have minor skin lesions, example, bruising or abrasians, on arms and legs due to their high activity level. Lesions on other parts of the body may be signs of disease or abuse, and a thorough history should be taken. Secondary skin lesions may occur frequently as children scratch or expose a primary lesion to microbes. With puberty, oil glands become more productive, and children may develop acne. Most individuals ages 12 to 24 have some acne. In dark-skinned children, areas of hyperpigmentation may be found on the back, especially in the sacral area. If a rash is present, inquire in detail about immunization history. Older adults, changes in lighter colored skin occur at an earlier age than in darker skin. The skin loses its elasticity, resulting in wrinkles. Wrinkles first appear on the skin of the face and neck, which are abundant in collagen and elastic fibers. The skin appears thin and translucent because of loss of dermis and subcutaneous fat. The skin is dry and flaky because sebaceous and sweat glands are less active. Dry skin is more prominent over the extremities. The skin takes longer to return to its natural shape after being tented between the thumb and finger. Due to the normal loss of peripheral skin turgor in older adults, assess for hydration by checking skin turgor over the sternum or clavicle. Flat tan to brown-colored macules, referred to as senile lentigines or melanotic freckles, are normally apparent on the back of the hand and other skin areas that are exposed to the sun. These macules may be as large as 1 to 2 centimeters, 0.4 to 0.8 inches. Warty lesions, seborrheic keratosis, with irregularly shaped borders and a scaly surface often occur on the face, shoulders, and trunk. These benign lesions begin as yellowish to tan and progress to a dark brown or black. Vitiligo tends to increase with age and is thought to result from an autoimmune response. Cutaneous tags, acrochordons, are most commonly seen in the neck and axillary regions. These skin lesions vary in size and are soft, often flesh-colored, and pedicled. Visible, bright red, fine dilated blood vessels, telangiectasias, commonly occur as a result of the thinning of the dermis and the loss of support for the blood vessel walls. Pink to slightly red lesions with indistinct borders, actinic keratoses, may appear at about age 50, often on the face, ears, backs of the hands, and arms. They may become malignant if untreated. Home care considerations assessing the skin. When making a home visit, take a pen light or examination lamp with you in case the home has inadequate lighting. If skin lesions are suggestive of physical abuse, follow state regulations for follow-up and reporting. Signs of abuse may include a pattern of bruises, unusual location of burns, or lesions that are not easily explainable. If lesions are present in adults or verbal-age children, conduct the interview and assessment in private. Document lesions in the health record by taking a photo, if agency policy permits and client consents. Because digital cameras are common, including on cell phones and tablet computers, clients can be encouraged to take pictures of their lesions in order to check changes over time, or to send to the health care provider. Another method that can be used to record lesion size and shape is to lay clean double-thick clear plastic, such as a grocery bag, over the lesion or wound and trace the shape with a permanent marker. Cut away and dispose of the bottom layer that came in contact with the client, and place the top layer in the client record. Use this method only if contact with the plastic does not contaminate the wound. Patient-centered care. Hair. Assessing a client's hair includes inspecting the hair, considering developmental changes and ethnic differences, and determining the individual's hair care practices and factors influencing them. Much of the information about hair can be obtained by questioning the client. Normal hair is resilient and evenly distributed. In people with severe protein deficiency, kwashiorkor, the hair color is faded and appears reddish or bleached, and the texture is coarse and dry. Some therapies cause alopecia, hair loss, and some disease conditions and medications affect the coarseness of hair. For example, hypothyroidism can cause very thin and brittle hair. Skill 30-3 describes how to assess the hair. Nails. Nails are inspected for nail plate shape, angle between the fingernail and the nail bed, nail texture, nail bed color, and the intactness of the tissues around the nails. The parts of the nail are shown in figure 30-9. The nail plate is normally colorless and has a convex curve. The angle between the fingernail and the nail bed is normally 160 degrees, figure 30-10a. One nail abnormality is the spoon shape, in which the nail curves upward from the nail bed, figure 30-10b. M30_Berm 4362_10_SE_CH 30.IND 528 April 12, 14, 11:03 a.m. Chapter 30 Health Assessment 529. Number 153613 CUST, Pearson, Berman PG Number 529 Title, Kozier, and Herbs Fundamentals of Nursing 10 EC/M/Y/K Normal Design Services of S4 Carlisle Publishing Services. Assessing the hair. Skill 30-3. Planning delegation. Due to the substantial knowledge and skill required, assessment of the hair is not delegated to UAP. However, many aspects are OB served during usual care, and may be recorded by individuals other than the nurse. Abnormal findings must be validated and interpreted by the nurse. Interprofessional practice. Assessing the hair is within the scope of practice for many healthcare providers other than nurses. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment: clean gloves. Implementation Performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. 2. Perform hand hygiene, apply gloves, and observe other appropriate infection prevention procedures. 3. Provide for client privacy. 4. Inquire if the client has any history of the following: recent use of hair dyes, rinses, or curling or straightening preparations, recent chemotherapy, if alopecia is present, presence of disease, such as hypothyroidism, which can be associated with dry, brittle hair. Assessment: normal findings, deviations from normal. 5. Inspect the evenness of growth over the scalp. Evenly distributed hair patches of hair loss, i.e., alopecia. 6. Inspect hair thickness or thinness. Thick hair, very thin hair, example, in hypothyroidism. 7. Inspect hair texture and oiliness. Silky, resilient hair, brittle hair, example, hypothyroidism, excessively oily or dry hair. 8. Note presence of infections or infestations by parting the hair in several areas, checking behind the ears, and along the hairline at the neck. No infection or infestation: flaking, sores, lice, nits, lice eggs, and ringworm. 9. Inspect amount of body hair. Variable hirsutism, excessive hairiness, in women, naturally absent or sparse leg hair, poor circulation. 10. Remove and discard gloves. Perform hand hygiene. 11. Document findings in the client record using printed or electronic forms, or checklists supplemented by narrative notes when appropriate. Evaluation: perform a detailed follow-up examination based on findings that deviated from expected or normal for the client. Relate findings to previous assessment data if available. Report significant deviations from expected or normal findings to the primary care provider. Lifespan considerations: assessing the hair. Infants: it is normal for infants to have either very little or a great deal of body and scalp hair. Children: as puberty approaches, axillary and pubic hair will appear, see box 30-9 later in this chapter. Older adults. Older adults may experience a loss of scalp, pubic, and axillary hair. Hairs of the eyebrows, ears, and nostrils become bristle-like and coarse. Home care considerations: assessing the hair. When making a home visit, ask to see the products the client usually uses on the hair. Assist the client to determine if the products are appropriate for the client's type of hair and scalp, example, for dry or oily hair. Provide education regarding hygiene of the hair and scalp. When making a home visit, examine the equipment that the client uses on the hair. Provide client teaching regarding appropriate combs and brushes, and regarding safety in using electric hair styling appliances such as hair dryers. Patient-centered care. M30_Berm 4362_10_SE_CH 30.IND 529 April 12, 14, 11:03 a.m. Number 153613 CUST, Pearson, Berman PG Number 530 Title, Kozier, and Herb's Fundamentals of Nursing 10 EC/M/Y/K /Normal Design Services of S4 Carlisle Publishing Services. 530 Unit 7 Assessing Health. Figure 30 to 9 The parts of a nail. Nail body. Nail root. Nail bed. Nail bed. Lunula. Posterior nail fold. Lateral nail groove. Lateral nail fold. This condition, called koilonychia, may be seen in clients with iron deficiency anemia. Clubbing is a condition in which the angle between the nail and the nail bed is 180 degrees, or greater, figure 30, 10C and D. Clubbing may be caused by a long-term lack of oxygen. Nail texture is normally smooth. Excessively thick nails can appear in older adults, in the presence of poor circulation, or in relation to a chronic fungal infection. Excessively thin nails or the presence of grooves or furrows can reflect prolonged iron deficiency anemia. Bowes lines are horizontal depressions in the nail that can result from injury or severe illness, figure 30, 10E. The nail bed is highly vascular, a characteristic that accounts for its color. A bluish or purplish tint to the nail bed may reflect cyanosis, and pallor may reflect poor arterial circulation. Should the client report a history of nail fungus, onychomycosis, a referral to a podiatrist or dermatologist for treatment of nail fungus may be appropriate. Symptoms of nail fungus include brittleness, discoloration, thickening, distortion of nail shape, crumbling of the nail, and loosening, detaching of the nail. The tissue surrounding the nails is normally intact epidermis. Paronychia is an inflammation of the tissues surrounding a nail. The tissues appear inflamed and swollen, and tenderness is usually present. A Blanch test can be carried out to test the capillary refill, that is, peripheral circulation. Normal nail bed capillaries blanch when pressed, but quickly turn pink, or their usual color when pressure is released. A slow rate of capillary refill may indicate circulatory problems. Skill 30-4 describes how to assess the nails. Planning delegation. Due to the substantial knowledge and skill required, assessment of the nails is not delegated to UAP. However, many aspects are observed during usual care, and may be recorded by individuals other than the nurse. Abnormal findings must be validated and interpreted by the nurse. Interprofessional practice. Assessing the nails is within the scope of practice for many healthcare providers other than nurses. Although these providers may verbally communicate their findings and plan to other healthcare team members, the nurse must also know where to locate their documentation in the client's medical record. Equipment none. Implementation performance 1. Prior to performing the procedure, introduce self and verify the client's identity using agency protocol. Explain to the client what you are going to do, why it is necessary, and how he or she can participate. Discuss how the results will be used in planning further care or treatments. In most situations, clients with artificial nails or polish on fingernails or toenails are not required to remove these for assessment. However, if the assessment cannot be conducted due to the presence of polish or artificial nails, document this in the record. 2. Perform hand hygiene and observe other appropriate infection prevention procedures. 3. Provide for client privacy. 4. Inquire if the client has any history of the following: presence of diabetes mellitus, peripheral circulatory disease, previous injury, or severe illness. Greater than 180-degree angle Bowes line. Figure 30-10A, a normal nail, showing the convex shape, and the nail plate angle of about 160 degrees. B. A spoon-shaped nail, which may be seen in clients with iron deficiency anemia. C. Early clubbing. D. Late clubbing, may be caused by long-term oxygen deficit. E. Bowes line on nail, may result from severe injury or illness. About 160 degrees flattened angle, 180 degrees. A, B, C, D, E. Assessing the nails. Skill 30-4. M30_Berm 4362_10_SE_CH30.IND 530 April 12, 11:03 a.m. Chapter 30 Health Assessment 531.